So it's a part 2 session on recall and surgery. So we will go through that, and once I post the question and option, you tell me is the question and option is relevant and does it mean the same as it asked in exam. Then once it is done, then we will discuss the answers with the correct reference and explanation. Okay. Question reads, medullary carcinoma of thyroid planned for central and ipsilateral neck dissection based on serum calcitonin level. So it will be, see, it's a controversy. See, doing a total thyroidectomy with a central neck dissection, yes, approved, correct. But doing a prophylactic neck dissection, that too on contralateral side. Affected side, yes, there are schools of thought that an affected side you can do it. On contralateral side, if you want to do, that is based on serum calcitonin. That's the question. So the right answer here is, it looks like 200 picogram per ml should be at least minimum. See this, I'll just go through what is given line by line in submission 21st edition, page number 907. Clinically evident medullary thyroid cancer is treated with minimal total thyroidectomy with bilateral central neck dissection. Yes, known. As a central nodal metastasis is present in 70% of cases. That's the reason why we do central neck dissection. So the role of routine lateral neck dissection level 2 to level 5 is controversial. One school thought advocates prophylactic lateral neck dissection, yes, on accepted terms if there is an ipsilateral involvement of the primary tumor on the ipsilateral side. As several single institution series have demonstrated not only more than 70% of incidence of ipsilateral lateral neck metastasis, but also more than 40% of incidence in the contralateral neck. So ipsilateral, the chances are 70% and contralateral it is 40%. So why not a prophylactic neck dissection? So the opposing opinion cites the morbidity of the lateral neck dissection along with the fact that 65% of patients with MTC have evidence of systemic disease even after bilateral neck and lateral neck dissections. Recognizing this controversy, current ATA guidelines, see the current ATA guidelines recommends that prophylactic ipsilateral and contralateral neck dissection to be considered based on serum calcitonin level. Very, very clear. This is the stem of the question. Question has already been discussed in the class. This is available in the app, in the speed learning app. For example, in patients with ipsilateral neck metastasis noted on the preoperative ultrasound. So there is an ipsilateral neck metastasis. If it is noted and documented by ultrasound, prophylactic contralateral neck dissection should be considered if the basal serum calcitonin level is at least 200 picogram per ml. So the minimum cutoff is 200 and above. The minimum is 200 and above. Is it very clear? So ipsilateral nodal metastasis is documented by ultrasound, and for a contralateral if you want to do it, and what should be the serum calcitonin level is the question here, is the basic question here asked, and the best answer will be 200 and above, because 50 to 200 is 200 and below. So we need to choose an option 200 and above. Is this answer acceptable to you? Great. So we move on to the next question. All the questions are very, very simple, and this is again from tables from Subistan. There is a separate module, tables in Subistan in the app. So, on all the tables of 150 questions, more than 80% of questions are from the tables. Now, high risk factor for IPMN all except word to word and aspect of from the tables. Mural nodule more than 5 centimeter. Subistan. Main pancreatic duct dilatation more than 1 centimeter. The discussion was on both contralateral and ipsilateral only was discussed. So ipsilateral is there and contralateral is there. What is the creatinine? Correct. What is the calcitonin? Very clear. Jaundice and pancreatitis. The right answer is pancreatitis. When you see here, the summary, Subistan 21st edition, page number 1548, and it very, very clearly says the main pancreatic duct dilatation more than 1 centimeter, enhancing mural nodule more than 5 centimeter, and jaundice. So 1, 2, 3, word to word taken from Subistan 21st edition. Is it clear? The worrisome features or the rest of the features as listed in the table. Clear? So let's go back to the question and see. So all are there. Mural nodule more than 5 centimeter, MPD more than 1 centimeter, jaundice, and pancreatitis is not an option given. Okay? All are risk factor for male breast cancer except. All are risk factor for the male breast cancer except family history, Klinefelter syndrome, BRCA mutation, gynecomastia. Yes, the answer is very clear and a simple and a straightforward question and discussed many times in the class. Risk factors related to a genetic predisposition include Klinefelter syndrome. Page number 852, 21st edition, line by line. So, Klinefelter syndrome number 1, BRCA mutation number 2. Yes, gynecomastia is not a risk factor. See that? Categorically given, gynecomastia is not a risk factor. So, family history, yes, family history, Klinefelter and BRCA, all are included. So, this is a family history, see that? Option 3. Clear? Very, very clear. 42-year-old patient, jaundice, severe abdominal pain, investigation, dilated intrahepatic duct, normal CBD. Okay? So, normal CBD with a gallstone. So, it looks like that. So, it is dilated intrahepatic duct and the normal diameter of the CBD. So, this is the question, right? So, there could be a cause of okay, could be a cause of a gallstone, aerodynamic ileus instead of Gallstone ileus. Okay, option B was a dynamic ileus. Is it okay? Now the question is correct. So, it is classically the Mirizzi syndrome. It's classically the Mirizzi syndrome and it is a very straightforward question. There are 2 questions on Mirizzi syndrome. Okay. So, dilated intrahepatic duct, normal bile duct diameter means obstruction above the common bile duct formation. Okay. The pain in the upper abdomen, suspected cholecystitis. See that? So, the obstruction of the bile duct, okay, from the inflammatory process is the hallmark of the syndrome and cholecystocholidocofistula may or may not be apparent. Okay. So, is this answer acceptable to all of you? We need to move a little fast. That is in a different question. I will come to that. Dilated bowel was there in a different question, not this question. We have one more question on that. Okay. So, histology shows orphan antinuclear diagnosis. So, this is typically a filler, correct? So, there is no need for a discussion. Yes. So, papillary fronds, okay, Samoma bodies, orphan nuclei, nuclear ingrooving and pseudo-eosinophilic inclusion bodies, correct? A, B, C and D, classical histopathological. So, in that orphan nuclei is of papillary CA, but this is the most specific, that is pseudo-eosinophilic inclusion bodies and nuclear ingrooving, okay, is the most, in case this question is asked in next exam, of all these 4, this is the most specific for PAP-CA. Is it okay? Most common malignancy after solid organ transplantation. Again a simple straightforward filler question and does not have any value on this. So, the right answer is squamous cell carcinoma. Again it is taken from Subiston, straight question. After transplantation there is an increased risk of developing most type of malignant disease, but the risk of particularly high for those tumors which has viral infection plays an etiological role. The increased risk of malignancy particularly have high skin cancer and PTLD. Most skin cancers are seen are squamous cell carcinoma. Squamous cell carcinoma. But basal cell and malignant melanoma are also common. The very same question we discussed. Okay. 25-year-old premenopausal women presented with Birat's 5 lesion, underwent lumpectomy a year back, now presented with a mobile axial lymph node on the same side. What will be the correct TNM staging? Very simple and straightforward question, does not have any difficulty level of thinking. So, the right answer should be obviously. So, because previously operated, so that means what it will be there. So, what will be the T? So, it will be TX. There is one more question similar to that, we will discuss it. So, it will be TX and it is a mobile axial lymph node, it will be N1 and MX. Okay. So, the right answer will be option C. We have one more question and on staging. It is there T, you can see here, TMI not I, it will be micro because less than 1 mm is called TMI, T1MI, less than 1 mm. T1A will be 1 to 5 mm and T1B will be 5 to 10 and T1C will be 10 to 20. Understood? Is it okay? Yes. So, post surgery primary tumor cannot be assessed. So, metastasis still doesn't assessed. So, in this given question. Okay, Maastricht classification is used for which of the following? Again, tables from Subiston and important from Subiston, this area. So, it's a very, very straightforward question. The answer is donation after circulatory death. So, DCD. So, it is given on page number 1544 in 21st edition. DCD donors can be grouped according to Maastricht classification. Category 1, dead on arrival in hospital. 2, resuscitation attempted without success. 3, awaiting cardiac arrest after withdrawal of the support. Category 4, cardiac arrest while brain dead. Category 5, cardiac arrest and unsuccessful resuscitation in the hospital. Very, very clear. Option D was standard. Even on that, I think the answer will not change. Okay. Thank you for the option 4. But even then, the answer does not change. 12-week pregnant women with the complaints of 2 centimeter lump in the breast, biopsy proved malignancy. Which of the following is correct on her treatment? Because last class we discussed this, and you just tell me. Now the options are made very clear. All these options are very clear, and last time we discussed it from Bailey, and now we are going to discuss it from Subiston. So the right answer will be lumpectomy. Last class also, I gave you this answer. Now even now the answer remains the same. Lumpectomy with axillary dissection followed by chemotherapy, because chemotherapy can be given after the first trimester. Okay, can be given after the first trimester. The effects on pregnancy on the breast cancers are increasingly understood, and it's thought that breast cancer presenting during pregnancy or lactation tends to be a later stage, presumably because of the symptoms are masked by pregnancy. However, in other respects, it behaves similar to the way of the breast cancer non-pregnant young women and should be treated accordingly. So, the treatment options include radiotherapy should be avoided during pregnancy, making mastectomy more frequent option than the breast conservative surgery, but that option is not here in the option for us. Chemotherapy should be avoided during the first trimester, but appears safe subsequently. Most tumors hormone receptor negative, and so hormone treatment is potentially teratogenic is not required. So, see, actually breast conservative surgery should not be done, but there is no other option. That's the reason why you club lumpectomy with axillary dissection, because usually you do a lumpectomy followed by radiotherapy to the chest and the axilla. So, because radiotherapy should be avoided, I think this is the best option that is available out of the options given in this question. Is it agreeable to you? So, lumpectomy plus axillary dissection is something similar to MRM only. Okay, here axillary dissection is done with an intention to see whether the axillary lymph nodes are involved, because in the question there is no mention on that. Okay. So, we need to identify the thought process of the examiner, what he is gone through and what is that he wanted. Every question has that process. Only if that process is worked out correctly and you get an appropriate answer. Yeah, that's what we say, because you try to understand, see, breast conservative surgery is not advocated. So, in breast conservative surgery, what you need to do? You need to do a lumpectomy or tumorectomy, then you need to do a radiotherapy. Why you give radiotherapy? Because to sterilize the axilla, correct? Here the axillary status is not given. So, you need to do a sentinel nodal biopsy. There is an option is not here. So, the best way is to do an axillary dissection and subject for HPE and see whether involvement is there or not. So, it serves two purposes. It clears the node and also gives you an idea the status of axillary lymph node status. So, there is no BCS without radiotherapy to the chest and the axilla, correct? That's to sterilize. Gardasil 9 vaccine acts against. So, only Gardasil was asked, is it? Okay. So, Gardasil 9 as given in Subiston 21st edition 2008 prevents HPV against an anogenital warts and CEN caused by HPV types 6, 11, 16, 18, 31, 33, 45, 52, 58. As was approved by in 2014 for males and females in age of 9 to 26. I think this, I don't know the numbers which were given are exactly the same. This is all from internet sources. All these are from internet sources and from the recollect from the students. So, exactly I don't know what exactly was asked. So, 11, 16, 18 is there, 31, 33 is also there. So, we will see which number is maximum. 31, 33, 16 and 18 is also there. 16, 18, 31, 33, all numbers is also there, correct? I think it encompasses almost all the numbers. So, I think Gardasil 9 includes everything, but Gardasil only has 6, 11, 16, 18. See, Gardasil vaccine is only for 6, 11, 16 and 18. If it is going to be 9, then this answer is appropriate. Is it okay? If they ask only Gardasil, it is 6, 11, 16, 18. If it is going to be 9, then it includes 16, 18, 31, 33, that option. Mammography shows this, a picture similar to that. Again taken from a Telegram group and a WhatsApp group. I don't know whether exactly the same was there or similar to this was there. But anyway, you let me know. Is this question correct? Similar picture. Okay, fine. Let's move on. So the answer is DCIS. So ductal carcinoma in situ. Why? Clustered microcalcification. Something called clustered microcalcification, fine, pleomorphic and linear. Okay, calcification clustered together suggests ductal carcinoma in situ. Page number 820, subsistent 21st edition. Okay, so this is a clustered. So these are clustered classification, microcalcification. LCS has neighborhood calcification. Inflammatory carcinomas and advanced breast cancer. Okay, mastitis carcinomatosa. The picture will be different. It will be a mass as such. It is going to be inflammatory carcinoma. So neighborhood calcification is LCIS. No characteristic mammographic finding is LCS. This question, as discussed in the last class also, even today also, but the reference is from subsistent. Last time I discussed on Bailey, now I am discussing with respect to subsistent. Okay, so but the answer remains the same. Answer does not change. The answer remains the same. There is no change in the answer, but the reference has additional information. Because last time I didn't comment on the stone size. This class I am going to comment on that. That's the reason why I posted this question again. The answer is more than 3 stones. So okay, porcelain gallbladder will, yeah, porcelain gallbladder, correct. Okay, is the question now right? Okay, not polyp, accepted, fine, done. So let's move on to the explanation. 21st edition, page number 15, 16, page number. The presence of gallstone considered to be the primary risk factor. Size more than 3 centimeter carry increased risk of cancer development. This is the number. Last time we didn't show the reference, now I am showing the reference. More than 80% of patients with gallbladder cancer have cholelithiasis. And gallbladder cancer approximately 7 times more common in patients with gallstone than those without gallstone. Type of stone does not correlate with the incidence of gallbladder cancer. Other risk factors include entities that may cause inflammation of the gallbladder, anomalous pancreatic biliary junction, choledochal cyst and primary sclerosing cholangitis. Very, very clear statements. So all this has risk. Porcelain gallbladder was mentioned specifically in Bailey. Okay, the last class we discussed it. Several studies have demonstrated that a percentage of single gallbladder polyp more than 10 mm carries increased risk of malignancy, and cholecystectomy are generally recommended. This is also accepted. Okay, which of the following is not a feature of malignancy? Escape from immune destruction, escape autophagy, escape apoptosis, local enrichment. All these are features of malignancy. Not a feature of malignancy is escape autophagy, because autophagy is a criteria of malignancy. Autophagy is particularly important for the growth of RS mutated cancers, RAS, such as pancreatic, lung and colonic cancer. So it is not escape, it is only autophagy. It is not escape autophagy. Ferroptosis is a recently discovered form of cell death that results from iron-dependent lipid peroxide accumulation. Page number 660 and 664, 21st edition of subsistent. Very, very clear. So it is again, this image is given here, the phases and the process that happens in cancerogenesis, and you can go through that. In the PowerPoint slide will be loaded in the app. Okay, which of the following is not a feature of acute cholecystitis? Wall thickness more than 2 mm, pericholecystic fluid, Murphy's sign, neck sludge. All are features of acute cholecystitis. I mean, is this question and options are right? What was option A given in the exam? Less than, yeah, that's what I want to know. So it's less than 2 mm, is it? Okay. Then it becomes the clear answer. So then it becomes a very, very clear answer. The answer is option A. Okay. So when we change, it becomes more appropriate. Pericholecystic fluid, Murphy's sign, neck sludge and wall thickness, increased wall thickness. And it is very, very clear. Transabdominal, page number 1500, 21st edition of subsistent very clearly says transabdominal ultrasonography is sensitive and inexpensive and reliable tool for diagnosis of acute cholecystitis. Okay. And in 85% sensitive and 95% specific. In addition, on identifying the gallstones, ultrasound can demonstrate pericholecystic fluid. Number 2, gallbladder wall thickening, and also Murphy's sign, documenting tenderness over the gallbladder. And sludge is also a feature, right? Sludge is also a feature. Everything is given, right? Everything is there. 1, 2 and 3. Fine, fantastic. Not a risk factor for breast cancer. Very clear-cut question and straightforward. This is a filler. This is a very filler question. And fibroadenoma is not a risk factor. All of us know that. Atypical rectal hyperplasia, lobular hyperplasia and floral hyperplasia, all risk factors. As given in Subsistent 21st edition, page number 821. Proliferative breast disease, atypical rectal lobular hyperplasia and LCIS. Which of the following is not a risk factor for developing pancreatitis post-ERCP? Except. So this was female sex, okay. Female sex. Indomethacin suppository. Suppository. Is it okay? Female age less than 55 years. Okay, fine. Added. Done? Right. Let us see. Acute pancreatitis is more common complication after ERCP occurring in up to 5% of patients. However, the incidence of this complication after ERCP could be as high as 15% in high-risk patients. Who are high-risk patients? Post-ERCP pancreatitis is more common in females. See that? Female patient, young individuals, in patients with prior history of ERCP-induced pancreatitis. So, one option is this, second option is this, third option is this. So, acute pancreatitis occurs more frequently in patients who have undergone the therapeutic procedures compared to diagnostic procedures. It is also more common in patients who had multiple attempts of cannulation and sphincter of Foley dysfunction and abnormal visualization of the secondary pancreatic duct after injection of contrast material, and the clinical course is mild if 90 to 95% of patients. Among the pharmacological agent to prevent ERCP-induced pancreatitis, the use of endomethacin has gained most attraction. See that? Is it okay? Well, let's go back to the question. Then it becomes more appropriate. So, female, young female is common, and previous history, yes, and age is the only controversy here, correct? Indomethacin is protective. Is the architecture of the question is something wrong? Which of the following are the risk factors except? So the answer becomes C. Is it done? Yeah. Which is not used in thyroid storm? Which drug is not used in thyroid storm? It's very simple. We use propylthiouracil, propranolol, leucoalsoidin. Yes, except we don't use aspirin. There is no role for aspirin. Correct? Aspirin does not have any role. A high index of suspicion is required to diagnose thyroid storm, to include patients with very high fevers. Of note, established underlying diagnosis of the cause of thyroid storm, should not be delayed treatment. When the thyroid storm is suspected, treatment should be started immediately with a focus on minimizing clinical manifestation, decreasing the thyroid hormone production. Beta blocker, propranolol or esmolol to control the tachycardia, hypertension, anxiety issues. Thionomides such as methimazole or propylthiouracil. So propranolol is used, antithyroid drug is used. Okay. Propylthiouracil is preferred as it decreases the peripheral conversion of thyroxine to more active T3. Okay. Iodine is then given as potassium iodide or leucoalsoidin, see option 3, to inhibit a thyroid hormone release, but must be delayed 1 to 2 hours after thionomide administration to prevent the iodine substrate from being used for more thyroid hormone synthesis. So let's go back to the question. So propylthiouracil, propranolol, leucoalsoidin, all these are used. A patient present with 12 mm of polyp. For fever, use paracetamol. 12 mm polyp in gallbladder with symptoms of cholecystitis, treatment of choice. So it's very simple. Hyperpyrexia, malignant hyperplexia, dantrolene sodium, cooling, ice sponging, all these are used. So it's a very simple, straightforward question. Laparoscopic cholecystectomy. 12 mm polyp. Because the risk of malignancy starts if it is more than 10 mm. Here what is given is 12 mm. So again, Subsistent reference, 21st edition, 1518. The most consistent predictors of malignancy is the gallbladder polyp or a single most polyp size greater than 1 centimeter and age more than 50 years. Cholecystectomy is generally recommended. The polyp larger than 1 centimeter can be safely be done as prophylactic laparoscopically. Very, very clear guidelines, very clear guidelines. So, polyps smaller than 1 centimeter can undergo surveillance to demonstrate stability. Very simple, straightforward question. So, 44-year female presented with 3 centimeter thyroid nodule which is involving the strap muscles with significant lateral neck nodes on the same side, ultrasound finding, TNM staging, age 48. Lateral neck mass, it is there, it is understood. Same, na? Lateral neck metastasis is given in the question, yes. Significant lateral neck nodes. Whenever you see the gross extrathyroidal extension invading only the strap muscles, see the sternohyoid, sternothyroid, thyrohyoid, omohyoid muscles, comes under T3B. Okay. When you see T3A or T3B, yes, age here it is given as 48 years. So, see this T3A or T3B, any N, nodal metastasis is also given, M0, correct, M0, it comes under stage 2 and in the question, and it has to be stage 2, correct, T3 stage 2. I missed this age factor, you are all right. So, the right answer is stage T3 and stage 1. Gallbladder carcinoma with the perimuscular involvement on the peritoneal side with no any serosa breach belongs to. It's a very straightforward question from tables. What should be the answer? Yeah, very clear. So, T1A is last class also we discussed in a different question, different format. 2 questions on gallbladder staging. T1A lamina propria, T1B muscularis propria, T2A and T2B. So, this is T2A because it is on the peritoneal side, perimuscular conductive tissue on the peritoneal side. So, perimuscular conductive tissue within the serosa, that means what? Tumor invades the perimuscular conductive tissue in the peritoneal side without involvement of the serosa or the visceral peritoneum. So, what is T2B? Tumor invades the perimuscular conductive tissue on the hepatic side with no extension to the liver. Okay. So, this clear cut answer T2A, very clear. 55-year-old lady with a known case of carcinoma of the breast, good prognostic status, PS, performance status, presented with a solitary 2.5 centimeter frontal lobe brain metastasis. Which of the following is a single best treatment? Isolated solitary metastasis. There are clear guidelines as given in suggestion for that. Yes, if you have marked the answer as surgery, excision is correct. See, metastatic lesion tend to cause a significant brain edema that initially will respond to steroids. Typically, dexamethasone is used to reduce the vasogenic edema. Anticonvulsants are used to reduce the likelihood of seizures, but generally given in patients who had seizures. When the lesion is initially encountered and no primary tumor is known, recommendation is stereotactic biopsy or excision should be done. However, if the disease is widespread, short life expectancy, the patient has a poor preoperative status, and consideration should be given to possible biopsy or radiotherapy and palliation. In the other hand, a solitary metastasis is encountered, a total surgical excision should be attempted followed by whole brain radiotherapy. SRS generally will be recommended if the surgery is not feasible. Okay. And when the multiple metastases are encountered, consideration should be given to the excision of the symptomatic lesions or the multiple lesions. Whole brain radiotherapy and hippocampal sparing whole brain radiotherapy or SRS. So, if there is only one single solitary metastasis as given in the question, surgical excision, this is a possibility. A 30-year-old premenopausal lady presented with 1 centimeter lump in the left breast, no any axial lymph nodes underwent lumpectomy. What will be the next treatment? Very simple. So, underwent a breast conservative surgery, then definitely adjuvant should be, all patients with BCS should undergo, correct, radiotherapy. Radiotherapy is the chest and the axilla, chest and the drainage. There is no doubt about it. Standard dictum. So, lumpectomy means a breast conservative surgery as given in 21st edition of Subiston and page number 845. For patients with an invasive breast cancer treated with breast conservative surgery, adjuvant radiation to the breast has been conclusively demonstrated to reduce the probability of recurrence and improve the outcome. Okay. Histopathological appearance. I don't know what histopathological appearance was given based on thyroid. What was given? Is that orphanine is the same or repeated in a different format? Papillary thyroid cancer was an orphanine. I think it's a repeat what we discussed already. Okay. Radioactive isotope used for differentiated thyroid cancer treatment for ablation. Yes, please. It's a simple, straightforward question. Again, it is a filler and does not have any value for the exam. Iodine 131 is it's a radioactive isotope that is used for differentiated thyroid cancer. Radioactive iodation therapy for iodine 131 for differentiated thyroid cancer based on the thyroid follicular cells have a unique ability to take up iodine. Very, very clear. So 906, 21st edition semester. Gustatory sweating, auriculotemporal syndrome, injury to the auriculotemporal nerve, regenerating fibers, grows into the sympathetic or the parasympathetic fibers supplying the sweat glands of the cheek. So it is stimulated and the sweating is because of what? It's due to what? During eating, the process of eating, smell and taste. Okay, starch iodine test, you know that? Test is starch iodine test and symptomatic management. Yes, Frey syndrome, gustatory sweating. Consequence of paroidectomy. Clear. A known case of CA breast presented with the headache underwent CT and started with intravenous treatment immediately. What is the best explanation for the above condition? So what is, is the question option right? Mannitol for ionic edema, steroid for vasogenic edema, both steroid and mannitol for vasogenic and ionic edema. What kind of edema was that? Ring enhancing lesion. So one option was cytotoxic edema. Is there a cytotoxic edema was there for instead of option D? Okay, added. Ionic edema, steroid was also given an option. Okay. Solitary lesion. The question, okay. Solitary lesion. For which option ionic edema or steroid was given? Which I should change? Ring enhancing lesion. Solitary ring enhancing lesion. Cytotoxic edema was given in the option of the question. Option, okay, fine. The best answer for this given question, because I have not seen the image, but still I feel, after talking to students who appeared for this exam, looking like a metastatic lesion, single solitary metastatic lesion. Metastatic lesion, significant brain edema that initially responds to steroid well. So, I think the best answer could be steroid. Typically, dexamethasone is used and will reduce the vasogenic edema. Okay. So, this looks very appropriate. Taken from standard textbook from 21st edition of service. Clear? So, anyway, this will be available in the app for you for your reference. A female presented with 1 centimeter nodule in the right lobe of the thyroid, on investigation found to have medullary carcinoma of thyroid without any nodes in the ultrasound. Neck. Which of the following is correct statement? Simple, straightforward, standard treatment protocol. A male patient, is it? Okay, a male patient. Anyway, the answer is very simple. We already discussed total thyroidectomy is central neck node dissection. Because we know that we have already discussed more than 70%. Yes, will have central neck node metastasis. So it has to be a routine that MTC is treated with minimum total thyroidectomy with bilateral central neck dissection. Because as central nodes metastasis are present in more than 70% of cases with palpable tumors regardless of the tumor size. Lateral we already discussed, ipsilateral and contralateral based on the image finding and also on the level of calcitonin. Should be minimum 200 and above. Not used in autoimmune thyroid disease. This question was well discussed and the same question is available in the app also, in the high yield series also. Exactly. ANA. List of all are there. The measurement of serum thyroid autoantibodies is useful in the diagnosis of various autoimmune thyroid disease, although their variable sensitivities and specificities require caution in the test interpretation. 3 most commonly used measured autoantibodies are anti-TPO antibody, anti-thyroglobulin antibody, anti-TSH receptor antibody. Measurement of TPO antibody, more accurate and most commonly used screening test for autoimmune thyroiditis. TPO antibody is positive over 90% of cases with autoimmune thyroiditis as well as 80% of patients with grave disease. However, it is also false positive rate of 10 to 15%. Measurement of TG antibody, thyroglobulin antibody is commonly performed with sensitivity of 80% for autoimmune thyroiditis and 30% sensitivity for Graves' disease and similar false positive rates for TPO antibodies. So, the answer is only ANA. 44-year-old women present with the gallstones and pneumobilia on ultrasound examination, dilated small bowel loops for this. She has given history of constipation last 1 month. What is the clinical diagnosis? So the right answer for this question should be Mirizzi syndrome. Because dilated bowel loops is a ileus. I mean, there is no specific finding here that there is a stone. This causing an obstruction here. So I cannot go for a small bowel obstruction. Okay, but the pneumobilia is there, so there is a communication. So very clear. So then it is Mirizzi's only. Okay, I mean, it is not my conclusion. It is what is given in subsistent. Okay, see that although most patients will have constant pain from obstruction, others can present with episode of discomfort because gallstones only intermittently obstructs the intestinal tract. Plain radiograph usually demonstrate air fluid level consistent with small bowel obstruction. Although a stone, an offending stone may or may not be identified. Pneumobilia, which may sometimes be identified only on a CT scan, is a ubiquitous finding because fistula that permitted the stone to pass to the duodenum and allows the air to enter the biliary tree. Air to enter the biliary tree. Because gallstone produces intermittent obstruction. I mean, even does not produce. It is not a gallstone ileus which is given here in this option. If there is an obstructive feature given in this question, then we can take it up. Gallstone ileus and small bowel obstruction are not the same, no? Is that different? Small bowel obstruction can be because of any cause. Gallstone ileus and obstruction are not the same. Mirizzi's was not in the option. Mirizzi syndrome was not in the option. This question tells us there is a fistula, that's it. Okay, adynamic ileus. That will be there because of cholecystitis. Constipation because of adynamic ileus, and dilated bowel is because of that. It's our features of cholecystitis. No, this is a clear-cut answer is only Mirizzi's. This is not small bowel obstruction. There is no specific. If this question is right, if this question is, this all the features of cholecystitis, Mirizzi's, and all this are the features. Because once there is a fistula tract which is opening up into the intestine, and this adynamic ileus will set in. Pneumobilia can be seen in a fistula itself. I mean, is that stone going down into the ileocecal region and causing an obstruction is the question here. I mean, that feature is not given here. Because it's a small bowel which undergoes adynamic ileus in cholecystitis and this complication of cholecystitis. Is it okay? Why adynamic ileus is one of the option, is it? Which instead of which option? Adynamic ileus. I'll remove it here, correct. So, I could not see anywhere there is a stone which has come down and to cause an obstruction at the ileocecal valve and to dilate the entire ileum and jejunum, and patient present. I'll tell you how the patient will present in a gallstone ileus. The patient will present with vomiting, abdominal distension, patient will be in shock, and the patient will be in shock, and if untreated, uncontrolled, if it is not treated, then he can land up in other complication because of the stone eroding into the intestine and causes going for sepsis. This is late, I mean this is rare, but it will be definite: vomiting, abdominal distension and shock. So none of these features are there. So it has just Mirizzi's which has happened, and cholecystoenteric fistula has happened, and it is only a dilated small bowel loops. It is not the entire small bowel is dilated. So the complication which has occurred, suppose the complication, if it is what can happen, if they ask you if that is the meaning, then small bowel obstruction can happen. What complication has happened already, then it is Mirizzi's. So two things that you can decide by yourself. It is a complication of what? It is a complication of Mirizzi's. Or what complication is expected is the line of question, then small bowel obstruction. Okay, because I cannot fix any answer without understanding the question what is asked in the exam. So I am just giving you the option. If this picture is there, This is because of what complication? Mirizzi. What complication is prone? The cause is cholecystoenteric fistula. See, I will tell you, you should understand, not all stones will cause small bowel obstruction, only large stones will cause. Smaller stones will pass without causing anything, and the features will be there. Once a fistula is formed, the patient will have all these features: dilated small bowel, ileus, constipation, all be there. And only larger stones causes obstruction. Doesn't mean that all Mirizzi syndrome stone entering into the duodenum or jejunum or ileum, wherever the fistula is there, and all will cause a small bowel obstruction. That's what I want to tell you. This typical picture of the complication has happened because of Mirizzi. But will this cause a small bowel obstruction? This history does not tell that. It can happen. I am not saying it may not happen. But with this alone, it is not. Okay, very clear. Happened is Mirizzi. What can happen? Small bowel obstruction can happen. What if this is because of complication of what? If they ask you, it is Mirizzi. And this condition can get into next to what complication is small bowel obstruction. Possibility is there. I am not saying no possibility is there. Possibility is there provided stone size is bigger enough, or else it will pass off. But fistula, this tract will cause these features. The take home message is all stone that is coming into the small intestine because of the fistula need not cause small bowel obstruction. It can pass also. Larger one gets impacted. Smaller one will get passed. Larger one will get impacted. But smaller stone can also cause these features. And fistulas also can cause these features. That's what I am trying to tell you. Fecal elastase value in severe chronic pancreatitis. Less than 100 microgram per gram per stool, 100 to 200, 200 to 300, more than 500. It's a very simple, straightforward, factual filler question. Less than 100 microgram per gram of stool. Measurement of fecal elastase level, preferred a non-invasive study to diagnose pancreatic exocrine insufficiency. It quantifies the amount of fecal elastase using monoclonal or polyclonal anti-human elastase 1 antibodies. Fecal elastase 1 concentration above 200 microgram per gram in feces is normal. Fecal elastase 1 concentration between 100 to 200 microgram per gram defines mild to moderate pancreatic insufficiency. Fecal elastase 1 concentration below 100 microgram per gram establishes diagnosis of severe pancreatitis of exocrine insufficiency. Less than 100 microgram per gram of stools. Very simple, straightforward question. No value again. Factual question. 6-week-old child presented with a non-bilious vomiting. What is the clinical diagnosis? Very simple. Congenital hypertrophic pyloric stenosis. Non-bilious projectile vomiting. 6 weeks. Yes. Firstborn male child. Yes. Rabbit pellet stools. Visible gastric peristalsis. Olive shaved mass. We have discussed a number of times in the class. Even we have not discussed also is a straightforward question. A 4-year-old child presented with a massive lower GI bleed. What is the most probable diagnosis? I mean, was this options right? Meckel diverticulum plus Meckel diverticulum ectopic gastric mucosa. Both options were there in the question. Because the most common cause of lower GI bleed in children is salt rectal polyp. Next to salt rectal polyp is Meckel diverticulum. If it is a Meckel diverticulum, only Meckel diverticulum will not have any complication. Meckel diverticulum with the ectopia, choristoma. Yes, ectopic gastric mucosa, which will cause a problem. It will cause diverticulitis, diverticular ulcer, diverticular bleeding. Yes, so the right answer will be option D. Simple, straightforward question. So I am moving on to the next. Gold standard diagnosis for Hirschsprung disease. Simple. Failure of migration of neural crust cells from the neural crust to the distal part of the intestine. Aganglionosis. And it's a very simple, straightforward question. The answer is rectal biopsy. To know that absence of ganglion cells and hypertrophic nerve fibers. It's a filler. So no more discussion required here for this question. Anyway, I have given you the reference. 47-year-old female with a known case of ulcerative colitis presented with obstructive jaundice. Simple, straightforward question. What will be the most probable cause of obstructive jaundice? Yes, it's a primary sclerosing cholangitis. No discussion again required. It's a factual question. Which of the following is wrong in the management of choledochal cyst? I need to know is the options are right because all are correct. All the options given are correct. Hepatectomy because it will have intrahepatic and extrahepatic dilatation. 4A, right? So both hepatectomy and excision of extrahepatic cyst will be required. So it was 4B, right? Then if it is 4B, then the answer will become A, because 4B is only extrahepatic dilatation. So then excision is only the option. So T3 is a choledococele, so you have to do a transdural excision. T5 is a Coriolis disease transplant, and T2 is a saccular diverticulation, so it again excision. All correct. Simple. I mean, I will not discuss this because it's known to everyone. Gastric secretion is not stimulated by. It's simple and straightforward question. Carbohydrates, rest will all stimulate gastric secretion. The release of gastrin is stimulated by page number 1119, 21st edition of Subiston, by proteins, bombacin, okay, release of meluminal acid by release of gastrin, specifically intragastric pH is below 3, and all this gastric distension. So all these are given in the options, right? And it is again a simple straightforward question. Dumping syndrome caused by all except. 1 is gastroduodenostomy, 2 is gastrojejunostomy, you know that. Then it becomes, this is more anatomical, dumping syndrome will be least. Rest of things, dumping syndrome will be more. Billroth 1, Billroth 2, pancreatic duodenectomy, and gastrojejunostomy. So Wilkie syndrome, all of you know, right? Wilkie syndrome is a compression of, it's a simple straightforward question, and this is the aorta, and this is aorta, this is superior mesenteric artery and duodenum. So duodenum gets compressed by the superior mesenteric artery with respect to the angle of aorta. So, and this is correct. Cast syndrome, Wilkie syndrome, and all this means the same. And it's again a simple straightforward question, no need of explanation required. So the vascular, we have discussed a number of times. Vascular compression of the duodenum known as superior mesenteric artery syndrome or called Wilkie syndrome. A patient presented with a perirectal growth underwent, and I need to know perirectal growth was an image given or which layer was involved, that is required to give an answer here. Perirectal growth, when you do an endorectal ultrasound, image was there. Okay. When the image was there, it was involving which layer? An image, you will see, no? Mucosa, submucosa, muscularis propria, serosa, or the peritoneal layer. It was involving which layer? So it is a muscular involvement, right? Breach of serosa. Because I didn't see the image, I just want to know from you. So you might have seen there, right? So breach of serosa. So based on that, you will get an answer here. See that? Tumor involving the submucosa is T1. Outer line was involved. Okay. Tumor invades the muscularis propria as T2. T3, colorectal tissue. T4A penetrates the visceral peritoneum. T4B, tumor invades into the adjacent organ. So which one you feel was given in the question? So all layers are involved, then it will go to T4. Is it okay? If all the layers, T4, okay, fine. If it is breach of serosa, then it has to go for T4. T2 is, that's what, that depends on what layer is involved, because I have not seen the image. I have just given you, according to there in the classification of Endo US Bailey and Love, 27th edition, page number 1333. So based on what is involved, because I was informed by students who wrote the exam, I had a preliminary discussion. They said it was involving the muscularis propria, then I made T2 as an answer. And now when you say it is beyond serosa, breaching the serosa, then it has to be T4. So you just take a call. Yeah, it needs an image. So based on that, you kindly make an answer accordingly. So ERAS protocol in colonic surgery, which of the following is correct? This is a discussed question, and this has been discussed twice, one in the regular class and on the high yield. The answer is pre-op carbohydrate loading is accepted today. There is a strong evidence to support, page number 1337, and it is given in Bailey and Love in 27th edition. There is a strong evidence to support recommendation of a clear liquid diet until 2 hours before the induction of anesthesia. However, there is a weaker evidence to support the use of pre-op carbohydrate loading prior to surgery. Except. Yeah, this question was, should we accept? Do you agree? Yes. So there is a weaker evidence to support. It's only a weaker evidence, pre-op carbohydrate loading. Boundaries of Peutz triangle is an inferior lumbar triangle, and it's a filler question, straightforward type of a one-liner question. Latissimus dorsi, external oblique and iliac crust. Peutz triangle, inferior lumbar triangle. Okay. So, and it is there in Bailey also. So, less common are the hernias through the inferior lumbar Peutz triangle bounded by iliac crest, latissimus dorsi muscle and external oblique muscle. Okay, very clear. Identify the correct statement. I think this is again a straightforward factual question. I mean, everything is autosomal dominant with respect to colorectal cancers. So the right answer is FAP, familial adenomatous polyposis coli is autosomal dominant. It is taken from Subiston 21st edition and page number 1369. See that, you can see FAP, juvenile polyposis and Lynch syndrome. This comes under HNCC. Okay, hereditary non-polyposis, colonic cancer. Everything is autosomal dominant except for MAP is recessive. Okay, and again HNPCC will be 60 to 80%. Okay, here it is given as 1%. So this is out, this is also out, this is also out. So the right answer is only FAP. A patient with a known case of ulcerative colitis presenting with the symptoms of obstructive jaundice, which of the following is investigation of choice? You know that we are discussing what? Primary sclerosing cholangitis. So what is the investigation you will do? It does not require any invasive methodology, and also the best and to be accurate and investigation of choice and gold standard. It is MRCP. Magnetic resonance cholangiopancreatography is the best answer. Now, imaging with cholangiography demonstrates a multifocal diffuse dilatation and structuring of the intrahepatic and extrahepatic biliary trees. This pattern is called beading or chain of lake and is characteristic of primary sclerosing cholangitis. MRCP is useful in the diagnosis and surveillance of primary sclerosing cholangitis patient, while ERCP is reserved for the treatment of dominant strictures and to exclude malignancy and namely cholangiocarcinoma. Very, very clear. So, MRCP is useful in diagnosis and surveillance of patients with primary sclerosing cholangitis. It was given in Subiston, page number 1503. An image was given like this: a 45-year-old man present with an upper abdominal pain and episodes of hematomesis. And and as endoscopy picture. I mean, what will you do? I mean, it's very simple. When you have to do an endoscopy and biopsy, and for staging you do a contrast and CT. So among the options given here. So this option, most appropriate option will be biopsy to prove its malignancy. Then for staging you will do contrast and CT abdomen. I mean, it's a workup. We have been discussing that in the class as well. No issues. Spurious diarrhea is a feature of colorectal cancer, especially C rectum. Spurious diarrhea, so it's a mucous diarrhea. Yes, it's a C rectum. So simple, straightforward. Patient may endo or empty the rectum several times. It's called spurious diarrhea. Spurious diarrhea. Yeah, endoscopic biopsy is what we mean also. Understood. Interleukin 2 is secreted by which cells? Correct, T cells. Bailey and Love, 27th edition, page number 1535. Very clearly said. Antigen presenting cell, MSC cells, helper T cells, and you see interleukin 2 is by T cells. 40-year-old female, severe chest pain radiating to the back after being alcohol and vomiting. See, this presentation can be seen in both Borhaves and Mallory ways. You need to tell me, is the question only given or something else was given? Is it upper GI bleed was given or anything else suggestive of Borhaves is there? Because this is a perforation of an esophagus, subcutaneous emphysema. Okay. Subcutaneous emphysema. Correct. So if it is subcutaneous emphysema, then it is only Borhaves. Correct. Or you can remove. Correct. Perfect. Amsterdam criteria 2 as all except. Again a simple straightforward question. At least relative of above or below 50 years. It should be below 50 years. Correct. It should be actually below 50 years. Rest all correct. FAP should be excluded. At least 2 generations affected. 3 or more relatives affected. Very clearly given. This is, we have discussed tables. Say, I request you, what you do today is go through tables in Subiston and tables in Bailey. You will find all this. You will find exactly all this. Only tables we have done in the class. Please. 80% of questions are only from tables. 3 or more relatives with hereditary non-polyposis colorectal cancer associated with cancers. See the criteria. 52.3. One affected patient is a first degree relative of the other two. 2 or more successive generations are affected. Cancer in 1 or more affected relatives are diagnosed before the age of 50 years. Familial adenomatous polyposis excluded. Pathological The diagnosis of cancer is verified. So all are there. All options are there. See that? This only is this. Should be below. Patient with polyps and perioral pigmentation, it is nothing but a Peutz-Jeghers syndrome. No discussion required. Perioral pigmentation is nothing else in Peutz-Jeghers. What else? And polyps. Hematomatous polyps. Okay. Mucocutaneous pigmentation. Peutz-Jeghers. Mucocutaneous pigmentation. Polyp. 21st edition, page number 1372. Montrell classification. Again, this is from table. Yes. Hope you remember this table. Yes, in tables in Sebastian. Okay. So, age more than 50 years, fistula, ileocolic. So, A3, B3, L3. So, it should be A2, B3, L3. Was an option there, but I couldn't find an option. That's the reason why I think I went for this. Was there an option for A2, B3, L3? Fine. So, I'll just rewrite it A2, B3, L3. I'm sorry, I didn't know. Because there was no option, then I went for this appropriate answer. Okay, fine. I think I'm done.